Hi, good evening, everyone. My name is Dr. Zayn. I'm working with Dr. Chan tonight to moderate this session. So last week, we went through about virtual fellowship interview. This session, we are going to talk about breast imaging education. We think it's a very timely topic because lots of our education has changed over the past year due to the pandemic. We had lots of remote learning. Also, on top of that, we just finished our fellowship interview. We have lots of great news and also some program not quite matched all of their spots. So we want to discuss how we can engage more medical students and residents to breast imaging. Also for people who have already decided to pursue breast imaging as their career, we want to learn from our panelists, how do you prepare yourself for your fellowship and how do you prepare yourself for a successful career in breast imaging. So first, I'd like Dr. Chen to introduce herself, and then I'll have our panelists introduce themselves.
All right. Hello, everyone. My name is Tiff. I am one of the assistant clinical professors in breast radiology at UCLA. I'm also obviously a member of the SBI social media committee. Very excited to be here and looking forward to our chat with everybody. We have some great, panelists with us today. So feel free to introduce yourselves.
Hi everyone, my name is Ida Du. I actually recently graduated from Cornell residency program, and now I'm about to start a breast imaging fellowship at UC San Francisco next week. I'm also a co-chair of the SBI Resident Fellows section, and I'm excited to be on this panel with such distinguished guests.
Hi, everyone. I'm Mitva Patel. I'm an associate professor of radiology at Ohio State University. I'm the fellowship director there, and I've also spent several years in charge of the radiology residents as they rotate through breast imaging. And I sit on resident education committee, so I have a particular interest in this topic, and I'm really excited to be here, and thank you for having me.
Hi, I'm Fadima Sharif. I'm about to be PGY4 R3 at St. Louis University Hospital residency program. I'm hoping to be in breast radiology, and I'm also part of the social media committee for SBI.
Yeah, tonight is very exciting because we have people at different stage of their career. So I think it's really valuable to hear a voice from people from different stage, and then so hopefully we can bring some very useful information to everyone who's in front of the computer tonight. And last but not least, I want to introduce myself. I'm Dr. Zayn. I right now is a fellow at University of Pennsylvania. I'll start my first attending job at Einstein, Philadelphia. So as I initially quickly mentioned, we had lots of remote learning during the pandemic. So first, I'd like to ask our panelists what you liked and you didn't like for those remote learning. And is there anything you want to keep moving forward as we transition more and more back to in-person learning?
I can start by talking about that a little bit. In terms of teaching trainees specifically, I think honestly there were a lot of negative. Residency and fellowship is like an apprenticeship, and I think that a lot is learned by just observation. And it's not just the medical knowledge, but it's how attendings interact with patients, surgeons, clinicians. There's some soft skills that you learn just by observation, and unfortunately, I think a lot of that is lost with with distance readouts and without just being right there in the reading room with attendings. So in terms of teaching, unfortunately, I think we missed out on a lot last year, and I am excited to have residents and fellows back in the reading room so that they can, really pick up on some of those soft skills, which are just as important, I think.
Yeah, that's actually such a great point because we learn so much just by watching what the physician, what our attending do, especially if we don't have those interaction to do shoulder to shoulder and then just to watch how you take cases, what's your search pattern. It's really hard to learn those skills just by, remote lectures.
Yeah, and questions that are very quick questions, we're less likely, or answers, it's just less likely to pick up the phone or do a chat if there's something that's very small, which could open up a conversation where you could identify that the resident or fellow just had a gap in their knowledge, and you had to go further on that. So again, I think in terms of teaching, I think that there were more negatives than positive. But I'm interested in hear what other people think.
I completely agree. So, at the end of the year, what we do at Cornell is we send out this annual feedback, and one of the most common feedback that we got for this past year was the loss in education with remote readouts. Especially for our junior residents, you lose out on those learning opportunities. How do you approach a case? How do you hang your studies? Where's the adrenal gland, for example, in a body CT, which can be challenging for people just starting off in radiology. So that was one thing that I'm glad we're getting behind us, and hopefully we're back to fully in-person readouts in this next academic year. One great thing that came out of this pandemic was creation of teaching files. So at our institution, a lot of the divisions wanted to enhance the learning opportunities. So they created a huge collection of interesting cases, a lot of bread and butter cases in each division. And they were listed in anonymized accession numbers that every resident and even medical student can look up, and they were able to look at the case at their pace, write down their answers, and then review those cases with the attendings. So even when the day was slow because of the pandemic, we still got to look at so many interesting cases, and those teaching files are always available to us. So I would say that's something that our residents loved, and that's something that I think we can keep from the pandemic.
Another positive thing was what we're doing right now, video conferencing. I think everybody has become much more comfortable with Zoom and video conferencing, and it's allowed us to connect to other people in different areas. And it's also it's just made education more accessible in terms of conferences. So I know that there's a lot of society conferences where potentially people couldn't attend, not just because of the financial burden, but also maybe childcare. And I think all of the major societies had a virtual option, so everybody could participate. And I think that is something that I hope stays in the future.
Yeah, I totally agree. I think those teaching files, that's such a great idea to share that. I remember at the early pandemic, someone also compiled all of the learning resources throughout the internet and shared through Twitter. I think that's great as well. And I think the remote lectures is probably, in my opinion, a controversial topic. Lots of people wants to go back to those in-person conferences, in-person lectures, but lots of people actually really enjoyed those remote learning lectures. So I'll see how things go moving forward regarding, which part we keep and which part will go back to in person.
Yeah, so I think in terms of reading out, definitely I don't really know of any positives regarding that, but in terms of lectures, I feel like we got a much bigger breadth of knowledge through the virtual learning. Instead of relying on guest lecturers and their availability to be able to travel to us, they were able to lecture us from the comfort of their home. We were also able to join other universities and other radiology programs in their lectures, which was really great. For our pediatric department, it's shared by Kansas City, UMKC. So whenever we were on our peds rotation, we were able to listen to their conferences as well. So we just got a lot more experience when it came to conferences, and I thought that was really great. And I feel like there was more of a sense of community online. I feel like it's kind of always existed for attendings, but not as much for residents. And I feel like COVID really emphasize how important it was for residents to kind of, connect. I think her name is Amna Farouk. At the beginning of COVID, she established a tutoring system where different radiology residents would be able to put their name on like a list and say which level of residency they were. And through that, I was able to meet like an amazing radiology resident in Kansas City who he basically just tutored me once a week for like 5 weeks, and it was great because I got to learn how like he studies and how his residency program functions, and it was a really great opportunity to like be able to connect to other people around the country.
That's really cool. That Fatima, that actually made me remember this. We had one of our breast attendings, Katya Dodelson, who's fantastic, also our associate program director. She collaborated with UCSF to put on these fun case competitions. So it was Cornell residents against UCSF residents, and we had it was like a 2-day trivia night where we would, we would have drinks at home from the comfort of our home, but we would sort of compete with the other residency programs. So it was like friendly competition. That definitely brought us closer together, and it was so much fun.
I also did my residency in New York City as Ida, and then we had the New York Lincoln Society. We have the resident sessions, case competitions among all the New York programs. We were in person every month up until COVID, and I feel like so sad when we stopped doing that. But I think that remote competition against the institution across country is actually really great for learning as well.
Yeah, it seems like there's a lot of really actual advantages, or that, some benefits that we've seen from this past crazy year. And being able to connect with people from different institutions is certainly a big one of them. I, of course, am looking forward to the time that people can kind of go in person as well. That kind of in-person connection is something that I've always really enjoyed at conferences. When I was a resident, noon conference, was actually pretty important in that sense. Yes, you learn a lot. You get to see all these great lectures, didactics, and case conferences, but there is a small part of it, a social aspect of it, right? Like that's when you get to see your co-residents who are all in different reading rooms doing different things. So I know that, some of our residents, I think, miss that kind of in-person aspect. So I hope that we, moving forward, have a good combination of in-person and kind of remote learning. So we have been talking a little bit about remote learning, and along with that, also the virtual fellowship interview, which we talked about last session. Every year with Fellowship Match, there are programs that don't fill. And maybe there are some better ways that we can try to engage more medical students and residents. What are some ideas that you guys have? And is there a role maybe for social media in that? We are the social media committee, so we have to ask.
Yeah, I think one of the obstacles for medical students to consider radiology is that they just don't get enough exposure to what we do early enough. Particularly, we frequently see medical students in their 4th year rotating through radiology and then discovering radiology and feeling like it's too late. So we really want to be able to get in front of medical students. So they know what we do and know that we, especially as breast imagers, we see patients, we do breast biopsies, and it's not just sitting in a dark room all of the time. So I think social media can help get out the word of what we do as breast imagers, that we have patient interaction, as I said. I think that there are certain platforms that may be geared towards a younger audience. Tiffany, I think you have a great Instagram account where you really are able to show people what you do as a breast radiologist and what your life is as a breast radiologist. So, platforms like that, I think, can really help, people understand that what radiology is as a career.
Yeah, completely agree. I will say, I think human connection is one of the most powerful factors that influence what specialty you end up choosing. So I think when it comes to boosting recruitment, and I think it's very important to be active in medical education. So on in medical school, there are a lot of opportunities for radiology to really get their voice in the curriculum. I know at Cornell, radiologists are often invited to give imaging relevant lectures to medical students starting in first year. So I think that that's a great opportunity to bring attention to our amazing field. And then in terms of residents, getting residents involved in breast imaging, I think it's great when you have attendings who really care about your education and prioritize residents' education, and also take time to get to know you as a person and help mentor you. And I think, when you have attendings who care about you, they become your mentors, they become your role models, and they do influence you. They do influence your decision as to what specialty to go into. So I think for us as breast imagers and future breast imagers, we could definitely focus in on engaging residents and medical students on the education and mentorship front in order to build build stronger connections and hopefully pull them into breast imaging.
Yeah, I was discussing this with Jill through email, but something I've noticed about our program is, whenever we have like an MS3, I talk to them a lot about radiology, and that doesn't really exist within breast radiology. For some reason, the diagnostic rotation is completely separate from like the breast department. And I don't know like why it's structured that way, but I found that medical students have like little to no experience within breast radiology. Even within us residents, for us to have the rotation before the application cycle starts, you have to express a very strong interest for going into breast radiology, because with all the requirements, the R4s have to get their months in. So it's kind of unfortunate, because I can definitely see, a missed opportunity for a lot of residents who may have enjoyed that, but again, feel like it's too late. Just as medical students, radiology is considered an elective, and after you're done with all of your core rotations and the rotations that your like sub-Is and stuff of the things that you think that you may want to go into, radiology is usually considered like one of the last electives that you end up going through, and by then it kind of does feel too late. I actually went through that experience myself, as I didn't have any radiology rotations because I had my core rotations and I kind of just picked within that. And towards like the middle of my fourth year, I happened to, because I had a week where I wanted to be home, and the only thing available was like a week in breast. And that just completely changed my whole life and my whole career trajectory. Is that 1 week in breast radiology, I got to see so many patients, I got to help with biopsies, and it's just something I just wasn't absolutely not aware of existing. And I've always been passionate about women's health, and I just didn't realize it was such a specific field. So I think just as like Ida was saying, maybe like exposing medical students to it through lectures. I know like we were exposed to pathology early on through our pathology lectures, and at the end of the lectures, they would spend like 5 minutes explaining what pathology really is and the different fields of it. So when radiologists do go speak to medical students, maybe it could be an opportunity explaining the different fields and, explaining, radiology just isn't for people who want to sit in a dark room and never interact with patients. There's, if you love interacting, with patients, and especially women's health, there's a career called breast radiology, and, kind of get that into the minds of them earlier on.
And, you had mentioned, and I had mentioned earlier too, how medical students sometimes in their fourth year feel like it's too late to apply to radiology. And I would encourage attendings maybe to help those students finish their applications and getting things through. And also, I think that there's a lot of residency committees where they might look at your research and not count it against you that you didn't do your research in radiology, but that you had the experience of doing research, and your letters of recommendation are coming from attendings in any field and not just radiology, because there are people who discover radiology later, and they may not have had that year or two to really get those letters from radiologists or to do research in radiology. But we don't want to discourage people who have discovered our great fields late. So I'm just encouraging students that even if it feels late, that we can help them get their application together, help them with their personal statement, so they can get through and make it in time for the match.
Yeah, that's something I try to talk to like all the rotating medical students about, because right now we're getting the incoming batch of MS4s who may already even have their letters of rec, and I always try to make sure to let them know, like, we don't hold it against you for finding out about radiology later on.
Yeah, I completely agree. I'm actually just take myself for example. I was actually thinking about doing IR coming into radiology, and I did the surgery internship, and then I did some IR research early on. Was involved in the IR committee, and I think that's one thing as a breast imager we really have to learn from our IR colleagues, because they did a great job with medical student outreach. The society have awards for medical students coming to the society for conferences. Even it's just $500, but it really helps for the students to cover some of the travel expenses. And also they created sub-I for the medical students to do an IR sub-I. And my IR attending always ask my program director, radiology program director, we have Columbia, so backtrack a little bit with this story. So we have Columbia medical students rotating through. They are usually just the second year, third year medical student doing 1 week of radiology. So my program director usually gives them 1 day of each specialty. And my IR attending always ask my program director to make sure that students rotate 1 day of IR, but breast we never really asked. So we only have one student throughout the years. She's interested in breast imaging. Somehow she learned prior to medical school, probably from friends or family members, and she asked to go to breast imaging. So she's the only one end up rotating breast imaging. So I think we really have to communicate with either the program director or the medical school liaison, whoever is in charge of medical school student education. When the medical students are rotating radiology early on, we want them to be able to expose to breast imaging. And also I feel like even for our residents early on, sometimes in bigger programs, they only just read screening. And it's really just a small portion of what we do as breast imagers. So I think because I was actually thinking about applying for breast imaging when I started my first breast imaging rotation in residency during my second year. So I mentioned to my attending, okay, I really want to have a whole exposure because I know some of the application, like even right now, some body fellow will tell me, because body fellowship, you have to decide so early. They basically had to put their application in before they even rotated breast imaging. So I think you really have to first in our residency structure, we want to really have them, the residents also have early exposure. Second to that, I think when the residents come on, we want to make sure they see some diagnostic, at least observe a couple of procedures, not just reading screening.
Yeah, we have, I give the medical student lecture in breast imaging, and we also have all of our medical students come in for one afternoon to shadow breast radiologists, and we have them basically go through a checklist. They need to see one ultrasound guided biopsy, one stereotactic biopsy, understand, the recommendations for screening mammography, and to watch a diagnostic workup. And I think when I give the medical student lecture, it's also a great opportunity for me to educate medical students who are not going into breast imaging what we recommend in terms of screening, and explain to them why we want women to be screened at 40 and screened every year. And I think that helps too. So I think you're right. We absolutely have to encourage breast imagers to ask to be in front of medical students, so we can not only encourage people to go into our field, but we can also educate those that are going to be ordering breast imaging in the future, and so they can understand why we recommend screening at 40. So that's a little bit of a tangent, but I think that was a good point that you made, Jill.
Yeah, I love that idea. Because I think we right now in my fellowship, we call the provider and the patient for the result. And I had a woman coming age 50 for her first screening mammogram, end up having cancer. And when I called the provider, and then she said, "Oh, I'm so sorry. I thought she doesn't need screening until she turns age 50." So I do think, when we are educating our medical students, that's such a great idea. We're educating our future referral physicians as well.
Yeah, I mean, that's super important. I mean, in a lot of medical school curriculum, I feel like radiology is taught as part of different rotations, right? So maybe part of OBGYN or family medicine, something like that. for breast imaging. Obviously, with body or neuro, they are part of other rotations. The only problem I see with that is that if you're a student going through those rotations, you may not really focus on the radiology aspect of it, right? Because if you're, let's say, on your OBGYN rotation, and you listen to some breast lectures, your focus is not going to be on breast imaging necessarily. You're just trying to get through the rotation and trying to do well. And in fact, you may be considering OBGYN. And so radiology kind of becomes just like this adjunct in the back of kind of people's minds. They know how important it is in every field. They know that there's some radiology part no matter what rotation they're in. But I think having a separate sort of dedicated radiology elective is going to be very useful for people to be like, oh, this is like its own career. If I do this career, I'm going to be learning head to toe radiology as opposed to bits and pieces that I kind of pick up along the way. And I think, exposing people to radiology is the first step that we can do. And maybe that's something that we have to do even before medical school. I don't know if you guys are familiar with this, but there's a lot of virtual shadowing that actually happens on social media nowadays. It's become very popular during the pandemic. And of course, it's for very ambitious, aspiring physicians, PAs, whoever, who used to be able to shadow people in person. And obviously, we're not really able to do in-person sort of events anymore. So all these great groups on social media basically recruit physicians to give just really short PowerPoint lectures about a day in the life of what they do, the kind of cases they see. Everything is de-identified. And actually, I've done a few of them for breast imaging, and so many people, because I can read the comments, of course, after, have, number one, no idea what a radiologist is. They think that other doctors are reading their studies, which kind of makes sense because oftentimes it's your family doc, let's say, who's reading the report, and you really don't know that somebody else created that report. So it's nobody's fault, really. And then also, a lot of people didn't know about breast imaging, that we do so many cool procedures. So even just taking a picture of, let's say, like a lidocaine needle, to be honest, is like pretty impressive because they don't even know that we're like holding needles. And like I said, this target audience is fairly young in the sense that a lot of them are college students and they're trying to decide if they even want to go to medical school. So I do see some potential in outreach, in that sense as well. So they come into medical school at least being like, oh yeah, I did remember like there was some radiologist who talked to me, and I think that that's all she did. I think it was only radiology that she did. That sort of thought.
That's awesome.
What sorts of platforms have you found to be most useful for this kind of shadowing, virtual shadowing?
Well, Instagram, I think, is probably the one I'm most familiar with. There's a lot of virtual shadowing pages, and they, you can reach out to them or vice versa. And when you are giving the PowerPoint, it's going to be by Zoom. I think it's broadcasted by YouTube as well. And then they also kind of advertise that, hey, Dr. Chan's going to be talking about radiology on like July 30th or something like that. And if you look at their page, it's really cool because they have so many different types of physicians that are talking. So, students are really getting to learn about like orthopedics or ENT, literally all types of different careers. That makes it very easy. Again, why remote learning can be very useful. It's a really unique experience that I don't think they could have gotten outside of the pandemic.
Oh, that's really cool. I'll have to check it out. I've seen the TikToks by urologists, which are hilarious. Yeah. But that's really cool to hear.
Yeah, I love that idea. I think it's just the earlier we can engage our students regardless as college students or medical students, the better. Because I think as we also I discussed with some of my friends, right now we want to be part of the patient's treatment team. Mm-hmm. Some of the breast center are actually close to the surgeon's office, to the oncologist office, and somehow has been removed from the rest of radiology. But that's a good opportunity for someone who's interested in breast care. And then, they can just really see what we do. We're really part of the patient care team. So I think to engage them through social media or even create sabai for medical students are all great ideas for us to engage future breast imagers. Especially right now, the job market is so good for breast imaging, and there are lots of openings positions, but they just cannot really recruit enough people. So I'm glad we heard different perspectives and learned a lot from each other on this topic. So just moving forward, once we decide whether we want to do breast imaging or not, there are different options for fellowship. We have mini fellowship for senior residents. We also have a full year breast imaging fellowship. Some programs have electives. You can expose yourself to some surgery rotation, pathology rotation, oncology rotation, and some program will have some body rotation or women's imaging rotation. So how do you decide what kind of a fellowship you want to do when you decide to pursue breast imaging?
So my recommendation is to think about what types of studies you want to read in the future first, and then find a fellowship that teaches you the skills that you need to read those films. So I remember early on in residency, I was deciding between neuroradiology and breast imaging. And I remember one neuro attending telling me to imagine walking into the reading room and seeing 30 post-op and degenerative spine MRIs on the list. And I remember thinking immediately, like, ugh. So that's how I knew early on that neuroradiology wasn't for me, and I would primarily want to be reading breast imaging. So you can try that maybe to decide on what type of studies you want to be reading in the future. In terms of mini fellowships, I think many fellowships are such a great opportunity for residents to really hone their skills. You're already a senior resident. You've learned all the different types of radiology, and you've also taken your core exam. This is your opportunity to really get the finishing details in your diagnostic abilities. And personally, you can do it in the field that you want to go into. So for example, for me, I did a mini fellowship in breast imaging because I knew that I was leaving this institution for fellowship. I'm going to UCSF. So I wanted a lot of time to spend at Cornell to learn how, my Cornell attendings practice breast imaging. But for others, I have friends who are going into private practice, and they would be they're doing their fellowship in body imaging, for example, but they know that they're going to be expected to read breast imaging in the future, so they were able to spend their mini fellowship time reading breast imaging. So I definitely think that there are a lot of I think mini fellowships are a great part of residency and are very customizable for your future practice.
I think that's a good point, Ida. There was an article in Academic Radiology that just pointed out that 85% of radiologists identify more than one area of specialty focus. So really, most radiologists that are in private practice are multi-specialists. And what I do when I advise residents is I sort of think of it as a major and a minor. And I say, what do you want to spend a year learning? And then when you're looking for a job, what else can you tell your employer that you can read as well? So you sort of have something that is your primary focus, something that you are most passionate about. And in my opinion, I think that's what you should do maybe your fellowship in. Although I do like your idea, Ida, of getting experience in two different institutions. But I think that if you want to get two different specialties, that you look to the subspecialty that maybe you're less interested in to do as your sort of your minor or your other area of focus. But I think in terms of breast imaging fellowships, I think the majority of the imaging the majority of time should be spent in breast imaging. I think at least 9 months. I know that you had mentioned that there's some fellowships that, you rotate maybe in women's imaging, or you rotate in pathology or surgical oncology. I think it's great, those options, but you want to make sure that you have plenty of time to become really an expert in breast imaging, because when you leave, that's the expectation. If you've done a fellowship you are the expert in that. And now there's so many different, modalities now. There's not just, mammography and ultrasound. There's, screening ultrasound, which ABIS looks to me really very different from ultrasound. And there's a learning curve. There's, obviously MR and all the biopsies that we do and contrast enhanced mammography. There's just a lot to learn as a breast imager. So I think that it's important to have plenty of time during your fellowship to just gain some mastery in breast imaging.
Yeah, I think myself included, when I decided on fellowship, I was actually keep an open mind when I applied for all different type of fellowships and on the interview trial. And when I, just my year, I was actually still doing in-person interviews. So I was able to visit and then just to hear people talk about their day-to-day. I kind of feel like I'm more and more leaning towards breast only. So once I feel like that interview trial really helped me to make my decision. I feel like I want to be an academic breast radiologist. As a academic breast radiologist, really you just read breast. So for anything else that I'm reading during that year, basically it's not gonna help me to achieve my goal of being an academic radiologist. So I decided to just go with a full year breast imaging fellowship. And then I really like the idea of having some electives in surgery, in oncology and radiation oncology. I feel like they really helped me understand our role in the treatment and also helped me prepare what are the potential questions the clinicians may be asking during the tumor board. And also helped me. I feel like they're actually learning from us as well, because there are lots of things they are not quite sure. They're like, oh, when do we order this? When do we order that? And, it's really a two-way learning, actually, when you're doing those electives.
Yeah, actually, I had a really good experience. It wasn't in fellowship, it's actually during my mini fellowship when I was a resident. I actually went to the OR one of the days and actually saw them do like a lumpectomy and a subareolar excision. And I thought that was actually really useful. And as many of you guys already know or will know, wire lokes or wireless lokes are probably our most difficult procedures. They can be very difficult. And sometimes knowing just how a surgeon is going to be approaching the patient can really kind of give you a context for your part of the whole day. So if you ever have the opportunity, my residency was a little bit more flexible. I asked for some time to go to the OR and to go to pathology. At any point, those experiences I think are useful. I agree with you, Jill. From my perspective, I always want to do academic breast. So I was totally okay with doing a full year of it. But even if I was going into private and I had to read other things, I think, having a longer time in breast is useful because there's a lot of subtleties that we have to learn. And I don't know if 6 months, for instance, is really enough for you to feel confident about it. And as Mitva said, the minute that, you've done any sort of fellowship in breast, people are going to expect, right, that you're going to be the breast person. So you better be armed with a lot of knowledge. So you could always kind of make up for that by doing a mini beforehand. My mini was, I think, 3 months beforehand. So I got a lot of experience. But just like Ida, I went to a different institution and I really want to be prepared, to be honest. I know that, some of my seniors had told me you should do mini fellowships only in things that you're never going to see again because it's your last chance, do neuro, do whatever. But for me, I was like, ugh, I'm going somewhere new. What if everyone's like a lot better than me and I don't remember anything from what I learned? So I made sure to do my mini right before I left. And I actually felt like at least quite comfortable at my level at that point. So there's pros and cons, I think, of that kind of structure as well, too.
Yeah, that's a really great discussion to learn about how everyone decide on their fellowship. And I also want to mention the mini fellowship at Penn actually is 6 months. So lots of the residents can use this opportunity to really prepare themselves for the future, if especially if they are going to private practice, they are doing breast and then they spend the time in breast imaging. It's almost enough time to be qualified as a breast imager per our standard, because we require minimum of 6 months. But I think that's pretty rare. Probably most like 3 months mini fellowship is more of the standard. And I agree with everyone. If you think you are going to private practice, it's a good idea to expose yourself to a mini fellowship of a specialty that you are not going into. But if you decide you are already doing academics, I think it's actually good to kind of learn from different people. So then you have more experience, more of an expert when you graduate.
I think so. I think what makes it a little bit difficult is that a lot of times residents and even fellows don't know whether they want to do private practice or academics. I can't tell you how many times people have come up to me and they say, and I have only been an academic, and they've only really had exposure to academic radiologists. So unfortunately, I think that makes it really difficult for trainees to really figure out what they should be doing with their time. Obviously, if you're going to go into academics, you can just focus on one area. But I think that, I wish that there was some way that we could really, and I think a lot of programs do a good job of maybe bringing in some private practice radiologists that their residents can really ask questions and get an idea. But most radiologists are private practice radiologists, and that's where really the majority of jobs are. So, I always think of it as that we need to make sure that we're training our radiologists to be good private practice radiologists as well. But I think that it does complicate the matter, because frequently we have fellows that they're applying for jobs, and sometimes it's based on geography. They know they want to settle in a city, and they don't mind academic or private practice, and it's really a matter of what job is open in that area.
Yeah, that actually reminded me when early on I wasn't able to decide. And the most common advice I got is actually just to try to keep a door open, try to learn as much skills as you can, so then you have more options, so you can go either way. And I think that's a good idea as well, especially when you don't know, just to learn more skills never hurts you, and it always prepare you better for the next opportunity. You don't even know whether where and when that will show up. So
No, definitely true. Hey, Ida, at your upcoming fellowship, are you guys doing any general call? I know you probably are doing breast call. Are you doing any general call?
There is general call. So UCSF, I think all the general call is done by all the clinical fellows. So regardless of whether you're in chest imaging, breast, we do have to cover general. And I think it's like inpatient, chest and body, and then final sign on plain films on the weekends. So it's a little terrifying, but but I think it's a great way to keep up our general skills, because who knows what the future has in store for us. As Mitva said, some cities, if my husband is a software engineer, so we might be limited to some parts of the U.S. And, depending on the job market, there might not be an academic institution hiring at that moment. So I'm going to see the silver lining of this general call as being good.
No, absolutely. The reason why I ask, we do the same thing at UCLA. So when I was a fellow, we had to take general call as well too. It really was not that much. There was nothing to be stressed about time wise, but of course it was different, going from fellow to attending in that field, signing off. But the reason why I kind of bring it up is because in fellowships where you take kind of a general call, it's actually a good thing, because you get to keep up some skills during your fellowship year. And just like you said, that's going to be a time when you're deciding on what kind of jobs you're looking at. So in case you do end up doing a job that includes other things besides breast, that general call is going to be very useful for reminding you of all the stuff that's out there, all the stuff that you really knew in residency, all that night flow and everything that you took. It's going to really reinforce that. So it's another good opportunity, I think.
Thank you. I'm going to remember those words going forward.
All right, guys. Well, that was a great discussion, I think, on fellowship, different structures, and that sort of thing. We have some kind of just some general questions, For some of you guys are looking to do fellowship, some of you guys are starting fellowship. A few of us have already done fellowship. So, what do you think are some ways that you can best prepare yourself for fellowship? Are there any books that you would recommend or that you are reading? What would you recommend for even residents, aspiring future breast radiologists to look into before they kind of get this whole process started?
You can never read the BIREX manual enough times. So I think at any level, I've reread it as an attending, and it refreshes my memory on several things. So I think that that's really always a great place to start. I'm glad that you brought up the topic of books, because I sometimes have this conversation with our residents, and I finished my training a while ago, and definitely was in the era where we read books, but I feel like the tendency is maybe to go away from that and to find there's so many other resources. So I always have this conversation with our residents. What are you reading, and do you need any resources, and do you need any tips? And I'm finding that a lot of residents are sort of going away from reading from reading books, but I'd like to know what you guys think. I know that there's some great YouTube channels. Obviously, residents can Google and read journals and find things on the internet. But I'm just interested in what you guys as residents and recent fellows are considered, what you guys consider must reads for residents and fellows.
From my experience, I think you're right. We've been leaning away from physical textbooks. I found YouTube so helpful. You can just search any topic. I recently watched a 2015 video by Dr. Heather Greenwood from UCSF about her approach to breast ultrasound. I found that so helpful. I also at SBI, at our annual symposium, there are dozens of topics of talks that are made available to you. As long as you've registered for the symposium, you can watch it for the entire year. ARRS also has a huge listing of educational materials that are free for trainees to use, and they have access to papers, also video talks that are available on various topics. Those are both really, really helpful. I think what was hopefully helpful to prepare for fellowship, because I'm about to start, but was spending the mini fellowship time in breast before starting breast imaging. And also just making sure that I follow up on all my cases, because when you're on screeners, it's great to match your results with the attendings in terms of findings, but you also want to make sure you follow it through. Look at what was done in the diagnostic imaging and whether it matches what you think your differential was, and then follow it up to the biopsy and the pathology results to see whether you were right or wrong. I think I think following up on all those cases for me during my mini fellowship time was incredibly educational.
That's a great point, Ida. I always tell residents too that PACS is also a teaching file. So anytime a woman came in with a breast cancer survivor, and just for her diagnostic imaging, if she had a diagnosis 4 years ago, 3-4 years ago, I always tell them, go back and take a look at the presenting mammogram, and take a look at the year before and see if that's something that we could have called, or just so that you could learn what the early signs of breast cancer are as well. So I think that that's a great recommendation to follow up on your calls, your BIRED zeros, your and your results as well.
Yeah, I think those are so helpful. We actually have next question about how to prepare your first job, but we may not have time to go fully into that discussion. But I want to just see that I think to follow up your own pathology is very important at the beginning of your career as well. That's how you improve as a breast imager when you're out of training, and also to go back to see, when you see a surveillance screening or a mammogram, and to go back to see how the cancer was presented is extremely educational as well, because you have to read so many screeners to see a cancer. But in retrospect, in that way, you actually end up like seeing more cancers, and also that help you to make your decision. Some of my attendings say if the cancer initially presented as calcification, it may be more likely to present as calcifications. If initially presented as a mass, then when they come back, it's more likely to present as a mass. So it help you to look for those subtle signs of recurrence as well. So I think those are extremely helpful, not only for getting yourself ready for fellowship, but also for your first job. And also whereas I think same story, like you cannot read enough of Barras. So I think I'm gonna start my first job as attending, and definitely first thing is to read the Barras again. So that's really helpful. As a as a resident, just to go back to the question, I actually find the core radiology, that the little red book, is pretty helpful for breast imaging. I find the Brad and Ham is not really the breast. I don't know about the new book. I read the old book. So that old book doesn't really have much breast imaging. The core radiology, the breast session is a little outdated. But other than that, I feel like it has a pretty good structure. So as a resident who just start doing your first radiology breast imaging rotation, so I feel like that's a good starter. I don't know what you guys think.
Well, I had some resources that I used during my fellowship. So, but I probably could have used it earlier. It's just I kind of relied on in-person learning, looking up radiographics articles, that sort of thing. But if I had to kind of do it all over again, I think I could have started probably on like the case review series a little bit earlier. Case reviews, I mean, there's different types, but there obviously is like an actual series called case reviews. And that's kind of what I used when I was studying for my certifying. But I remember thinking and being like, if I could do it all over again, I could have just like read this like kind of sort of casually throughout my fellowship, because it's very fast to read. And it's not like a long textbook. Like none of us have patience for that like anymore. They're just like little snippets, like little stories. And then like on the other page, there's like an answer. So you get like quick satisfaction as well too. And you don't have to dedicate that much time to it. So I really liked, I still think that there is some value in textbooks, and that certainly is what helped me get through like my certifying. And there are some books also by Shaw that I really liked as well too. So I think those, can the old school ways sometimes can help. Interestingly, I have never like watched like a YouTube like lecture outside of like SBI, I don't think, which is kind of funny that we've mentioned it, because I never use it as a learning source. Maybe for procedures or something, like on how to do a stereo, like I'd rewatch that, when I came back onto Memo, and I was like, what do I do? So I think there was some benefit in that as well too. That's my experience.
Tiffany, while you are talking, I actually reached out to my case review book. Is this the one that you want?
That's so funny. Yes,
yeah,
I think it's so useful.
Yeah.
And like I said, I don't have a great attention span for long books anymore. I don't know if I ever did. But the case studies are really useful. And plus, they go through a lot of pathology that we don't really see. Like, I don't even know when the last time I diagnosed like a tubular cancer was. Like I get IDC, smattering of ILC, all the basic common ones that we obviously are seeing a lot, but you should be technically able to understand like the more unique sort of or I guess less frequent cancers, and if anything, for logistic purposes, it's going to be on your certifying exam anyway. So that's how I learned about it.
Yeah, I use that book for my core exam, and now we actually also want to ask any advice for the certifying exam. Perfect, you answered that question, and I actually kept that book, despite my moving, and just to want to refresh my memory with all the questions for the certifying exam.
Yeah, I think those books were good. There's something by Shaw, Shah. I feel like there were two books by him. One that was probably a case series sort of book, and then I think another one was like a question and answer sort of book. So those I used a lot. I actually, so, as a certifying exam, you have to you choose 3 sections that you have to do. A lot of people who end up doing fellowships in breast or let's say MSK, whatever, they do all 3 sections in their section because that's what they end up knowing the most. And for those of you that aren't as familiar, the certifying exam is what you take after fellowship. It's generally, I believe, in September. So for people who do kind of the routine fellowship and they're on track and everything, it's going to be like maybe the first few months that you become an attending. So the fun never ends. And so you take this exam, and it's much shorter than the core, obviously, but the scary part is that there is some general radiology as well too, right? So you choose 3 sections of what you want, and then there's going to be the same general questions for everyone. So that's why your general call really does help. I actually went back and looked at what's that guy, the Crack the Core book. And some of the snippets that he would talk about in general for the general stuff. I know that things have changed though since I've been through it. I think a lot of questions have kind of deviated farther away from that series. But I definitely needed to review something, I think, for the general part since I spent most of my year in breast.
So Tiffany, you reviewed Crack the Core as well before the exam?
Very briefly. It's obviously it's a huge book. But I reviewed it very quickly, especially for the sections that I just didn't have as much experience with, let's say MSK. So I was like, I haven't seen, complicated MSK stuff in a while. I have no idea what's going to be on here. So I would just do it very quickly.
Yeah, I actually bought the question bank, bought Vital, not to we don't get any money from anybody. So yeah, and I haven't started, but just to refresh my memory about general radiology session as you. So, and I think it's just for us who has been doing breast imaging the whole year, and I do have some general calls, but I only have 1 week, so not sure how helpful that week is. But I actually want to mention about physics. I think physics is actually really helpful for breast imaging, even for day to day. Because people, when you interact with our women, some women may ask question, oh, why does my breast need to be compressed? It's so uncomfortable. So I think your knowledge of physics not only help you pass all the exams, it can really help you with the day-to-day interaction with patient, and also with the ultrasound. Why? Okay, I tell people this is a perfect cyst, and then the woman will ask me why this is a cyst. I have a friend who also have a dark thing in her breast that turns out to be cancer. So I think, then you can explain, oh, you have the through transmission. What's through transmission? Then your physics knowledge will come into play. So I think to learn well about physics is helpful both for the exam and for real life for breast imaging. Okay, so looks like we only have 2 minutes left. Just want to see if anyone have any last comments, suggestions, advice for our audience.
Yeah, I hesitate giving advice since I've only done 1 breast rotation. But I have never enjoyed reading textbooks, but I will say that the breast radiology textbooks have actually been really helpful. And I started the core review series, and I think it might be similar to the case review that Dr. Chen was talking about. And it is actually kind of nice to casually read.
Well, one last thing I'd like to say is, I think that we had talked about offline is that if you could go back and do your fellowship all over again, what would you do? And I think I just want to mention that I did not get involved with societies until much later in my career. And I think that there's so many resources. I know, Ida, you said you're on a committee for, is it SCI? There are resources for residents, fellows, and even young professionals that are geared toward their stage in their career. So these are discounted memberships when you're a resident fellow, and I think that that's a great resource.
I know we only have 30 seconds left, but I actually did want to ask Mitva and Tiffany if you can do fellowship all over again, what would you do differently? Since fellowship is about to start, this is my main question.
I think that's it. I think you're doing it, Ida, is that you are, you're active in societies, and that helps you make connections, and you learn through peer mentoring and other people. And I think that, I was just focused on where I was, and I didn't, reach out and become involved like that. I think you're doing a good job, and they're lucky to have you.
Oh, thank you. Cool.
I think one thing that I did not appreciate as much is that you get to work with so many different attendings, right? That's your job as a fellow. So that also means that you work with different perspectives, different search patterns, different thresholds for calling a BI-RADS 3 versus a 4. And you don't get that kind of opportunity like ever again in your life, because then you're the one who has to make the decisions. And you can always obviously ask your peers for their, opinions and that sort of thing. But at the end of the day, you spend the majority of your time listening to yourself. So fellowship is very useful in residency as well too, because you get to see how the whole range, the whole gamut of how different successful attendings approach patient care, and what we call, what we see, and that sort of thing. Take the best out of all the people that you know. Maybe, try to figure out who you relate to the most and use their skills. I mean, you have the best opportunity to pick and choose the greatest qualities of all your attendings. So you can kind of use that and be like, okay, I want to be like this person, I want to be like that person. It's a really unique sort of experience, I think. And I don't think I appreciated that enough, because now I'm in this position, and I don't get to work in that sense with everyone like I used to. So I do miss that a little bit.
Thank you.
Yeah, that's a really great question Ida asked. I feel the same. At the beginning of my fellowship, I think I was just basically learning the system, getting the logistics, but you really have to put yourself as think you are attending, think you are making your independent decision. I think that way you actually learn better, and you find out who you relate to more, and then who you agree more, and to find your own style. So, but I'm sure you'll do great. I had such a great discussion with everyone, and thank you all so much for being here today. I learned a lot, and I hope everyone in front of the computer also learned a lot from our session.
Thanks for having us.
Thank you, everyone.
Everyone.
Thank you. Hi. That went perfect. Thank you so much.
Thanks, guys.
Thank
you.
Comments that I was asking if the resources could be posted. I started a list of what you guys were saying, but is there a way I can comment back to that person? I'm not really sure how.
On Facebook, we can. I know that we can do that. It looks like that post maybe was on Facebook. Is that why it looks?
I think so. Yeah. It has a Facebook icon. So I'll just go to the Facebook website. But I wrote down. So I wrote that breast imaging, a core review, crack the core, ACR BI-RADS Atlas. Was there anything else that you guys suggested?
You said Dr. Shaw.
Oh yeah.
Yeah.
Dr. Shaw is on his book.
A core review is Dr. Shaw.
Oh, I see. Okay, sorry.
Yeah.
I think that's all I really use.
Yeah.
For BI-RADS,